Hello, good morning. This is a talk on management issues in thyrotoxicosis. So please listen to this. Thank you. So the first case is what I'd like to call all that glitters is not gold. So this is a case of a 55-year-old male who is a smoker. He had history of viral fever about a month back. Now following this, the patient had history of weight loss, he had fever on and off and had tremors. Now, when we examined him, he had tremors present. The heart rate was 110. The blood pressure was on the higher side. He had a small goiter, but classically, when you touched it, it was a tender goiter. So there was significant tenderness there. There's an upper eyelid retraction. However, there was no exophthalmos. So we ordered the thyroid function test. The total T3 was on the higher side. The total T4 was also elevated and the TSH was low. So this is a typical thyrotoxicosis. Now, at this point of time, I'd like to pause and tell you that thyrotoxicosis is not equivalent to hyperthyroidism. So when we use the terminology thyrotoxicosis and we use the terminology hyperthyroidism, both are not synonymous with each other. Now, thyrotoxicosis is basically increased level of thyroid hormone in the circulation. Now, it could be multifactorial. There could be many reasons why there are increased thyroid hormones in the circulation. It could be because the thyroid gland is producing more hormones. It could be because the thyroid gland is damaged, leading to release of the preformed hormones. Or it could be that you have taken these hormones from outside. So that is exogenous thyrotoxicosis or iatrogenic thyrotoxicosis. So it could be any of these reasons. So thyrotoxicosis is an umbrella term. Whereas when I say a patient has hyperthyroidism basically means that the thyroid gland is producing more of thyroid hormone. So when we discuss with our patients or when we discuss in clinical circumstances, it's appropriate to use the term thyrotoxicosis when we are not sure about the etiology of the same. But when you know that the etiology is increased thyroid hormone production from the thyroid gland, then we use the term hyperthyroidism. So this clinical picture which we have so far is described as thyrotoxicosis and not hyperthyroidism so far. So what would be the next step in management of this patient? Now, unfortunately, we do not have the ability to sort of have a question answer or dialogue, but I'd allow you to think for a moment in your own brains of what you will try to answer. So would you start this patient on carbimazole straight away? That's the first question. Would you start the patient on a beta blocker, propranolol? Yes or no? Or would you consider further evaluation for this patient? Now, one of the common challenges that we see in clinical practice in such a patient is that without evaluation, a lot of these patients are started straight away on carbimazole. Beta blockers again, should be prescribed to this patient, but they are often not prescribed, and leading to the fact that patient often tends to continue to have symptoms. Now, one clinical pearl I'd like to give you is that when you talk about symptomatic relief or urgent symptomatic or instant symptomatic relief, the symptomatic relief is actually, in a case of thyrotoxicosis, it is actually provided early on by your beta blockers. So adequate beta blocker dosage is very important to maintain symptom-free patient, and the patient actually feels better in the initial phase with the beta blocker. Even if the patient has Graves' disease where carbimazole is indicated, even in that patients, you need to give beta blockers for symptomatic relief. So in this, the right answer, like in clinical practice, there's no right or wrong answer, but the ideal answer in this case would that we would consider further evaluation in this patient, and that would be ideal. So what further evaluation would you do? So would you consider doing an ultrasound with a Doppler? Now, why ultrasound with a Doppler? Because ultrasound gives you the anatomy of the thyroid gland. Sometimes when you have infiltration of lymphocytes into the thyroid gland, you have a picture which is described by radiologists as thyroiditis, but technically I believe that radiologists should not use the term thyroiditis because it's a clinical diagnosis. Along with this, we often use a Doppler. The Doppler is important because if there is increased blood flow in the thyroid gland, especially in the inferior thyroid artery, that often is suggestive of Graves' disease. Graves' disease is a condition where there is hypermetabolism, there is increased thyroid hormone production, and hence there is increased thyroid circulation. Would you consider doing an anti-TPO antibody? Now, that's a contentious issue. Recently, I actually listened to a talk by endocrinologist from the UK who actually said that topic of the talk was anti-TPO antibody it's a useless test. It's a completely useless test. It has very limited indication for use. So in this scenario, would you consider doing an NT-TPO antibody? And what I've seen in clinical practice is that a lot of these patients, you do an NT-TPO. And I'll tell you why that's not an ideal test in this scenario. Would you consider doing a TSH receptor antibody in this patient? And like you listened to the earlier talk, especially by Dr. George, where he said that TSH receptor antibody is important in pregnant women to diagnose Graves' disease. So TSH receptor antibody in this patient, you have a patient with thyrotoxicosis. Would you consider doing that? Yes or no? Or would you consider doing a thyroid scan? In routine, most of the time we consider doing a technetium scan, that is a technetium 99 per technetic scan. Would you consider doing that? Yes or no? So I'll give you a moment to think about these answers in your mind. But the correct answer here, like I said again, there's no correct or wrong answer, but there are three things you can do. And you can do either one of these, or you can do all three, or you can do any two, right? Depends on your choice. So in this, you can consider doing an ultrasound with Doppler. It's completely a fair investigation, but it's an operator dependent thing and you need a good radiologist to make a diagnosis. You can do a TSH receptor antibody, which is, when you have TSH receptor antibody positive, it is suggestive of Graves' disease. Whereas when it's negative, you think of other etiologies for this patient. Or you can do something very simple, that is to do a per-techneted thyroid scan. Now this thyroid scan, it doesn't take too much time. It's a quick, effective test. Not very expensive now, considering TSH receptor antibody, the cost is similar, at least in our setup. It may not be, however, available in smaller centers. So hence, that's possibly a problem. A TSH receptor antibody is now done by most labs. So it's also known as TRAB antibody. So you can also, talk to your lab, and they have, often tie-ups with referral labs. So even if you're in a smaller center, you can consider sending this test, which is, and generally the turnaround time is within a day or two. So why should you not do an NT-TPO antibody? Now in this scenario, an NT-TPO antibody basically is not going to change your management, right? So what you need to understand is you should order tests which should change your management, and there's no point in ordering tests which do not change your management. So basically, in this scenario specifically, the NT-TPO antibody will not change your management. So in general, if you talk about general prevalence of NT-TPO antibody in population, this is a study done from Iran, where they interestingly showed that in a mean population with an age of 40 years, at baseline, about 12% or 13% patients had TPO positive. So this is basically cross-sectional study done across in a population, and you'll find 12 to 13% patient has TPO positive. Now, if this patient has TPO positive, how is it going to change your management? If it's negative, how is it going to change your management? It doesn't really change the management in this scenario. So you should not consider doing an NT-TPO in this specific case. Now you can consider doing a thyroid scan. The thyroid scan, you have two options. Either you can do a thyroid per-technetic scan, or you can do a radioactive iodine scan. Generally, a per-technetic thyroid scan is good for diagnosis. So it's generally one which we prefer. It is quicker, it is easier, it is much easily available, and you do not have to wait too much to order the isotope and so on. So it's generally available in most of the nuclear medicine center. Now I know there are certain radiology centers also which perform the same. You need a gamma camera, but it's really straightforward. So in this case, we did a thyroid scan, and in this we found that the thyroid scan, there was a reduced uptake. Now, what's the importance of this interpretation? So broadly speaking, when we talk about causes of thyrotoxicosis, we can broadly divide it into two categories. One is thyrotoxicosis because of increased uptake of technetium or radioactive iodine, or conditions where there is reduced uptake with technetium or radioactive iodine. So let me give you a corollary of this. So for example, you say, there is a particular brand of chocolate. For example, let's say you have dairy milk chocolate, right? Now, let's say suddenly, you are surveying your local stores, and you find that suddenly there is an influx of dairy milk chocolate in the store. So the entire store is full of, dairy milk chocolate. A lot of them are there available on the shelves. Now, there could be two reasons for this. A smart person would think in two ways. One, there is increased demand for dairy milk. So hence, there is more, the Cadbury company is making more dairy milk chocolates, and hence flooding the stores with dairy milk chocolate. The other scenario, though a little grim scenario, would be that the company is now going out of business, and they have a pending stock of dairy milk chocolates, and they just want to use up this stock before they close their shop. So this is the scenario, right? Now in this scenario, how do you correlate that with thyroid? You see that in your circulation, you have increased thyroid hormones. So your T3, T4 hormones are increased. Now it could mean two things. Either the thyroid gland is producing more thyroid hormone, which is what is known as hyperthyroidism, in which case there is increased uptake of the technetium or radioactive iodine, or there is increased destruction of the thyroid gland leading to increased thyroid hormone in the circulation, right? So what happens is, let's say the thyroid gland has some storage of thyroid hormone for a rainy day, right? And if there is a damage to the thyroid follicles, all this stored hormone is released into the circulation, leading to thyrotoxicosis, in which case when you do a radioactive iodine or thyroid scan, you will have a reduced uptake. So the same scenario when you talk about in the case of chocolate. How would you know that the Cadbury company is making more because of more demand, or is it making more because it is going out of business? The simple way would be to trace the supply of the raw materials. So you talk to the raw material supplier in the local area and you talk to them. Is the factory which makes the chocolate, are they asking for more milk and cocoa and so on, or sugar and so on? So have they put a higher purchases for these raw products, raw materials, or has the demand for raw material actually reduced, right? So if the company is asking for more raw materials, that means the company is hyperactive, the company is actually producing more Cadbury chocolate to meet the demand. But if the milkman says, or if the supplier to raw materials, the sugar guy says that since the last few months Cadbury company has not ordered as what they usually do, in this case it means that there is something wrong going on. The company is not producing more, is actually just distributing the existing supplies into the market. So the same way, if the thyroid gland is asking for more iodine, and iodine being a raw material, if it's asking for more iodine, that means the factory is overactive. It is producing more thyroid hormone from the thyroid gland. But on the other hand, if the iodine is the demand for iodine is less, the iodine uptake is less, in that case what is happening is the thyroid gland is not functioning. Whatever is there in the circulation is what is released preformed. So hence it's a very good idea to differentiate the causes of thyrotoxicosis into two categories. One is there conditions where there is increased uptake, and the other is condition where there is reduced uptake. Conditions where there is increased uptake typically include conditions like Graves' disease or autonomous thyroid gland, where you have a toxic adenoma or toxic multinodular goiter. These are common causes, whereas conditions where there is reduced uptake, this is typically seen in thyroiditis. The most common cause of thyroiditis is subacute thyroiditis. You can also have postpartum thyroiditis or some other forms of painless thyroiditis. It could also be because of exogenous thyroid hormone intake. So the patient is taking iatrogenically or factitious hyperthyroidism, or it could be some ectopic, some other gland is producing thyroid hormone, which happens in case of stroma ovary or metastatic follicular thyroid cancer. So this is the first good step to differentiate causes of thyrotoxicosis, whether there is increased uptake or reduced uptake. So thyroid scan is a good test to consider whenever available when you are dealing with a patient with thyrotoxicosis. So in this patient, we actually had a reduced uptake. Along with that, the patient had clinical symptoms which are suggestive of painful thyroiditis, that is a subacute thyroiditis. Now remember, subacute thyroiditis is actually not an uncommon cause of thyrotoxicosis. It's actually quite common. In fact, you see especially in the viral infection season, and which is the biggest viral infection season, it's a current pandemic, COVID-19. So we have seen a lot of patients post COVID-19 developing subacute thyroiditis. In fact, we have seen this we have had case reports published all the way in Journal of Clinical Endocrinology and Metabolism, the JCEM, where early on, almost a year back, they had reported cases of subacute thyroiditis post COVID-19 infection. So post COVID-19 or any other viral infection, there are many viruses which are known to produce subacute thyroiditis. Typically, a patient with subacute thyroiditis presents with typical symptoms of thyrotoxicosis, that is weight loss, patient has fever, patient has tremors, all these things are there, the heart rate is increased, the pulse rate is increased, so on and so forth. But clinically, you will find that the patient has a painful thyroid gland. So if you touch it, the patient has a tenderness in the thyroid gland. Typically, subacute thyroiditis or any form of thyroiditis goes through different phases. Initially, you have a hyperthyroid phase, then a brief euthyroid phase, Then you may go to onto a hypothyroid phase. The hypothyroid phase may remain hypothyroid, or the patient may go on to have recovery, ultimately leading to euthyroidism. So this is a typical course of thyroiditis. So this patient did not have Graves' disease. This patient actually had thyroiditis, and thyroiditis is also an important cause of thyrotoxicosis everywhere. So a patient with thyroiditis, we generally treat this patient with beta blockers initially during the symptomatic thyrotoxic phase. We give NSAIDs. In some cases where the patient has typically severe symptoms, you can consider giving glucocorticoids. Glucocorticoids works beautifully in this case, where typically the symptoms often resolve instantaneously with glucocorticoids. Reassurance, of course, and then follow-up of these patients at a regular basis for a few months till it resolves. So important take-home message is, all cases of thyrotoxicosis are not Graves' disease, and you do not start carbimazole in all patients without first evaluating. So carbimazole is not indicated in subacute thyroiditis. In such cases, basically the management is, it's a self-resolving condition, and the management is basically beta blockers, NSAIDs and glucocorticoids if necessary. Okay, so this was the first case. Now let's look at the second case. That is what I'd like to call it as off target. So this is a 40-year-old male, a lawyer. He had history of weight loss. There are no classical signs of Graves' disease. The patient had a TSH of 0.12 and he was started directly on carbimazole, right? So this is what happened to this patient. Now, without further evaluation, and this is something which I very commonly see. So TSH is just the TSH is done, and the patient is started straight away on carbimazole. Now I'm not debating the fact whether carbimazole was indicated in this patient or not, right? We'll come to that. But what I'm saying is that this patient is started on treatment without complete evaluation. So what is your take for this, right? So my take is, do not start carbimazole before assessing the patient first. Okay, so patient, thankfully, for whatever reasons, did not start carbimazole and goes for a second opinion. So goes to another physician for a second opinion. The second doctor does a TSH and T4, but does not do a T3. Right now, you had a talk by Jabbar sir who said that T3 is a very unreliable test. I completely agree, but he also said that in certain situations T3 is important, right? And this is one of the situations. I'll tell you why. So the TSH is low, but T4 in this patient was normal, which is interesting, right? So what next? So the patient then is confused. The doctor is also confused, right? So he does not know what to do, right, in this patient. So the patient is then lost to follow-up. So he says that fine, I don't think I don't have anything. But he continues to be symptomatic, continues to have weight loss, symptoms become worse, and starts now having exophthalmos, right, eye signs. So then he goes to another doctor who then orders a T3, T4 and TSH. And he finds that the patient is now having overt hypothyroidism and then starts him on carbimazole, right? So this is what happened to the patient. So the diagnosis was, patient basically in that initial phase where the T4 was normal, the patient perhaps had T3 toxicosis. Now, what is T3 toxicosis? T3 toxicosis is a situation or a case of hyperthyroidism where the T3 is high, T4 may be normal, and TSH is low. Now, this is one case where T3 is really important, right? This is especially important in Indian context where you often have regions of India where you have iodine insufficiency. Now, what happens is that when you have limited resources, the body tries to conserve these resources for the best benefit. So, for example, if you have a patient with Graves' disease, so patient has Graves' disease, but the patient is actually iodine insufficient. So patient does not have adequate iodine. So what happens in such a scenario? So like, coming back to the chocolate factory kind of situation, you have Cadbury company which wants to make more dairy milk, but it does not have adequate cocoa. So what it does is it conserves it. It puts less cocoa in each of the chocolates, or it produces smaller chocolates. Same way, what the body does is, in situations where you have iodine deficiency, but you have Graves' disease, in such a scenario, the body conserves. So instead of making a T4 molecule, it directly produces more of T3 molecule. And generally speaking also, in Graves' disease, you have more T3 formed compared to T4 in general situation. So hence you tend to have T3 toxicosis in such a scenario. In fact, you also know that some of the patients with this also happens in something like primary hyperparathyroidism. Because of deficiency, the patient do not have adequate symptomatic disease. So in this case, what I'm saying is that if the patient has Graves' disease, an autoimmune disease, but the patient does not have adequate iodine in circulation, hence the patient does not have adequate thyroid hormone production, and the patient may continue to have a subclinical disease rather than an overt disease. But because this disease is mainly because of TSH receptor antibody, the patient can have eye signs. So sometimes the eye signs manifest early, right? And the patient clinically may not have other signs of Graves' disease. So the patient was then started on carbimazole. The doctor followed him up and regularly followed him up with TSH without T3 T4. Now this is another mistake which we often make in clinical practice. So how do you follow up? So the first point here was that carbimazole was definitely indicated eventually, but it's also important to do a complete thyroid function in your patients with suspected Graves' disease. So you do a T3, T4 and TSH, not just a T4 and TSH, not just a TSH. The second issue is what we'll come to in this case here. Whenever you treat a patient with thyrotoxicosis or a patient with hyperthyroidism, here I think hyperthyroidism is a better word to use here, who is started on carbimazole, the aim of the treatment is to normalize T3 and T4. That's the first aim. So the first aim, this is very important. So again, if you've not been listening to my talk, completely, this is one point we should listen to, because I see this very commonly, this mistake being made in practice. When you are treating a patient with hyperthyroidism with anti-thyroid drugs, your target should be to normalize the T3 and T4. That should be your first target. Don't chase the TSH. So what I've seen is, a patient is started on anti-thyroid drugs. So patient is started on carbimazole. The patient's T3, T4 becomes normal, but the TSH is still low. I've seen doctors increase the dose of anti-thyroid drug, leading to iatrogenic hypothyroidism. This is what exactly happened in this patient. So patient was continued to be followed up on TSH without T3, T4. So when the patient came, the patient eventually came to me. His TSH by that time was already in a hypothyroid range. So TSH patient was already having TSH of 20. So the treating doctor who had seen him, he reduced the dose of his carbimazole from 40 to 35, right? And since the last few years he was taking a 40 milligram of carbimazole. So basically what happened here was patient was overcorrected, overtreated, because the doctor was trying to chase the TSH rather than chase the actual targets, which were the T3 and T4. So this is an incorrect approach. Remember, in diseases like Hashimoto's or Graves' disease, unlike Hashimoto's, Graves' disease can actually undergo remission. This also, we discussed in one of the earlier talks. Basically, Graves' disease, when you use anti-thyroid drug, the disease can actually go into remission. So if the doses are not titrated, what you do is you basically, initially what you do is you start the patient on higher dose. Once you achieve a T3, T4 in a normal range, then you can start reducing the dose to achieve a maintenance dose. So important take-home message from the second case is that whenever you're dealing with a case of thyrotoxicosis, order a complete thyroid function, T3, T4 and TSH. All cases of thyrotoxicosis are not Graves' disease and do not need carbimazole. When you're treating a patient on carbimazole, you start the patient, you monitor with T3 and T4 and not with TSH. That's the important message. And do not down titrate the dose. What you can do is basically use a therapeutic dose and then a maintenance dose. That is what you typically do. The third case is again a common problem that we see in clinical practice. That is what I'd like to call it as the infinity. So this is a 55-year-old patient diagnosed to have Graves' disease 7 years back. The patient was started on carbimazole and continued taking carbimazole 40 milligram for a long time. So the patient again was lost to follow. Her thyroid function shows elevated T3, T4, but the dose was never adequately titrated. So the patient took the medicine on and off. The patient remained thyrotoxic for a long time. Right. So since the 7 years, the patient is taking the same dose of carbimazole. The dose was never up titrated. The patient did not take it properly. Right. There were issues with that. So what will you do in this patient? Right. Obviously, you optimize the dose of carbimazole, but how long to give carbimazole? That's an important question. So would you give it for 1 year? Would you give it for 2 years or 18 months to 2 years, or would you give it for 3 years? Right? Important question. Remember, when you are treating a patient with Graves' disease, assuming of course you have diagnosed the patient to have Graves' disease, what we do is, so typically let's say a patient comes to me, right? A patient has clinical symptoms suggestive of Graves' disease, right? You do a TSH receptor antibody or you do a thyroid scan which shows increased uptake and the TSH receptor antibody is positive, or the patient already has thyroid eye signs. In such a scenario, you start the patient on a treating dose of carbimazole. So generally we start with a higher dose initially, maybe 30 or 40 milligram. You monitor the T3 and T4 and you titrate the dose of your anti-thyroid drug based on the T3, T4 values. So let's say the patient comes on follow-up, the T3, T4 is still high. You can up titrate the dose of anti-thyroid drug. If the T3, T4 has come to normal, in such a scenario, you can down titrate the dose to achieve a maintenance dose. Generally, in these patients, we give the maintenance dose for about period of 2 years, and after 2 years, you can repeat the the TSH receptor antibody. And if the TSH receptor antibody is negative, you can consider stopping the antithyroid drug because the patient might be in remission. But let's say the patient continues to have TSH receptor antibody. In such a scenario, the patient continue to require antithyroid drug. In this case, you can consider two things. Either you can continue small dose of antithyroid drug, and now studies have shown that small dose of antithyroid drug given for a long time is generally benign, does not lead to any problems. However, the patient must be counseled for the potential problems with antithyroid drug, that is possibility of agranulocytosis or perhaps certain other cholecystic hepatitis and so on. If the patient agrees to that I'm fine with it, a small dose of 5 to 10 milligram of carbimazole may be continued for the long time. But you also need to understand that there are alternative options for treating such patients. You have treatment with radioactive iodine or treatment with surgery. Now, we don't consider surgery nowadays because you have radioactive iodine available. So surgery is not the usual option in most patients. So, but you can consider counseling your patient for these two permanent treatment options. So, typically what you have to remember is, and this is something you should always remember, radioactive iodine, there is often, like Dr. George talked about, a lot of misconceptions doing the rounds in the society. One of the often commonly, perhaps, I don't know where it came from, but a common misconception is that, and one physician often told this patient that, no, you should not take radioactive iodine, because if you take radioactive iodine, then you have to stay away from your children and others in your family for 6 months, which is surprising. That is not the case. When radioactive iodine, generally we use a very low dose, generally 15 millicurie, 10 to 15 millicurie of radioactive iodine is used, and generally this does not require staying away from your partner or from children for a long time. The only criteria is that at night time, of course, if you're sleeping with other adult, you should avoid it for just 3 to 6 days, and with pregnant women you should avoid it for about 15 to 18 days, or children for 15 to 18 days. At daytime, you can in fact return to work in a day. You can avoid public places for 1 day. You can avoid contact with pregnant women and children for about 1 to 2 days, and keep a distance of about 3 feet to 6 feet from pregnant women and children for the initial 1 to 2 days. So that's all you basically need to do. Radioactive iodine does not continue to emit radiation for a long time. It often gets washed out. Remember, the dose given here is very, very less compared to some of these things. May actually be necessary for patients who are given very high doses of radioactive iodine, often in situations of thyroid cancer. But in general situation, you can actually use a public transport also, after a day or two. So you don't need 6 months. You just need to stay away from pregnant women at night time for 6 days. That's all you need to do. So the important message here is, consider a finite duration of treatment with carbimazole. Consider a treatment plan for a patient on carbimazole. If you're giving carbimazole, up titrate and down titrate on the right time. And consider alternate therapeutic options for patients who continue to have relapsing form of thyrotoxicosis, that is relapsing form of Graves' disease. The next case is a case of what is I'd like to call it as a secondary problem. Now, this has already been discussed by Dr. Kumaravel in his first talk, but I'll tell you one of the common errors that is made. So, a 40-year-old woman consults you with secondary infertility, consults a doctor for low TSH. Now, a 40-year-old patient has low TSH, but the T3, T4 are not done. So again, she has history of severe postpartum hemorrhage during her last pregnancy about 8 years back. Following this, she had lactational failure and amenorrhea. So what would you do in this patient? So you just have a TSH value which is low. The patient has infertility. So would you start this, and amenorrhea. So would you start this patient on carbimazole? Would you start this patient, would you wait for T3, T4 reports? Would you start this patient on PTU, or would you ask for a thyroid scan without a T3, T4 report? So basically, you need to first check the T3 and T4 report. And in this patient, right, she had low T3, low T4 and low TSH. So this patient did not have hyperthyroidism at all. This patient basically had central hypothyroidism, right? So this is an important thing you have to remember. All low TSH is not hyperthyroidism. So this is something, and again, the first talk by Dr. Kumaravel, this was adequately discussed. So this patient, basically we did an MRI, had a partial empty sella. What this patient had was actually Sheehan syndrome. Sheehan syndrome is not an uncommon disease in Indian scenario. typically have patients with low T3, T4. The TSH may be either normal, high or low. You often have a history of severe postpartum hemorrhage. You have a history of lactational failure. You have a history of secondary amenorrhea. You have often unexplained hyponatremia and hypoglycemia. You have a characteristic listless pale face. One of my assistants often says, these patients look like ghosts. Not an kind thing to say, but they have a pale, listless face, a typical face. If you see a patient with Sheehan, you will often, see them enough, you'll recognize them. You often have an empty cella on an MRI, right? So these are things you should keep in mind. So the point here I'm trying to make is all low TSH doesn't mean hyperthyroidism or thyrotoxicosis. A low TSH can also be seen in patients with central hypothyroidism, and that is something you should. So always do a complete thyroid function, T3, T4 and TSH, at least in the context of when you're dealing with a suspected case of thyrotoxicosis or central hypothyroidism. The last case is again something which Dr. George already discussed. So I'll quickly run through the case. This is a 20-year-old female with 10 weeks of pregnancy. She's having hyperemesis gravidarum. A thyroid function test is ordered which shows slightly elevated total T3 and total T4 with low TSH. So what would you do next for this patient? Would you start the patient on carbimazole, start the patient on PTU, or would you evaluate further? Answer is to evaluate further. So the patient we ordered a TSH receptor antibody which was negative. So this patient we diagnosed as having gestational thyrotoxicosis. Now remember, a total T3 and total T4, do not compare it with a non-pregnancy range. A total T3 and total T4, remember, in a patient with pregnancy will be often higher than a non-pregnant female. The reason being that you have thyroxine binding globulin, and increased estrogen in pregnancy increases the thyroxine binding globulin, leading to higher T3, T4 value. So to solve this problem, you can do one of the two things. Either you can ask your lab to give you the pregnancy specific ranges for T3, T4 according to their reports, or secondly, typically characteristic what we do is, especially after the first trimester, we multiply the normal range which is given, non-pregnant range, and multiply that by 1.5 to get a pregnancy reference rate. This is an approximation. The third thing, of course, you can do is order a free T3, free T4. If it is reliably there in your, if you have a good reliable free T3, free T4 report from your lab, you can consider doing that, right? So this patient had mildly elevated total T3, mildly elevated total T4 and low TSH. Such a scenario can be seen in a case of gestational thyrotoxicosis. This has been adequately covered by Dr. George in his talk. So basically we followed this patient up, and this patient had normal thyroid function in the subsequent pregnancy, subsequent follow-up. Why do you have gestational thyrotoxicosis? Gestational thyrotoxicosis is because of HCG hormone. HCG hormone, when in pregnancy we know that HCG hormone increases. Whenever you have a very high level of a particular hormone, you have something known as specificity spillover. So this high HCG then acts on the thyroid gland, the TSH receptor, leading to increased production of T3 and T4 by the thyroid gland, and this increased T3 T4 then in turn suppresses the endogenous TSH. So this produces a situation where you have a low TSH with mildly increased T3 and T4, and in such a scenario, especially in those patients where you have suspected gestational thyrotoxicosis, we can consider doing a TSH receptor antibody or a thyroid ultrasound with Doppler if TSH receptor antibody is not available, to differentiate from Graves' disease, right? So this is something you should take in mind. So I'll just give you my take-home messages. In patient with suspected thyrotoxicosis, order a complete thyroid function test first. Always, please do this. It's very simple. Order a T3, T4 TSH. It's very simple to do, right? All cases of thyrotoxicosis, all are not Graves' disease, and all patients do not need carbimazole. There are different modes of treatment for different patients. Treatment of Graves' disease should be finite. You should plan your treatment for a patient with Graves' disease. It should not be that you start the patient on carbimazole and patient lifelong take carbimazole. That should not be done. In targeting patient with Graves' disease, your first idea is to normalize T3 and T4 and not to chase the TSH. That's very important. A low TSH can also suggest central hypothyroidism. So all low TSH is not hyperthyroidism. And for thyrotoxicosis in pregnancy, rule out gestational thyrotoxicosis, which is much more common than Graves' disease in pregnancy. So these are important things you have to keep in mind. You can visit our website, endocrinology.co.in. It's a very interesting site. We put evergreen notes on endocrinology. We have some notes on thyrotoxicosis also. So all of these things which we discussed, plus more, you can find that on this website. So thank you for a patient listening. And I once again thank Dr. Kumaravil sir for inviting me for this talk. Thank you.